This is Jeremiah Pfeiffer, and you're listening to Science from the Source. In today's episode, we discuss how the use of aerobic and resistance exercise can have a positive impact on the health of men undertaking androgen deprivation therapy for prostate cancer, as I speak with Dr. Brad Wall, who is a lecturer in exercise science at Murdoch University. Brad discusses the beneficial use of exercise in cancer patients, and then discusses his 2017 article, Exercise Improves VO2max and Body Composition in Androgen Deprivation Therapy-Treated Prostate Cancer Patients, which was published in Medicine and Science in Sport and Exercise. Brad, thanks for coming on the show for a second time in 2 weeks after we recorded an episode already with you, and then I erased it all. So you're back for round two, and we're going to try to make sure I record this one and keep it in the vault.
Yeah, thank you. If you didn't appreciate my first version, you probably could have just told me instead of deleting it. But that's okay. We'll try again, and I'll try and do better this time.
So today we're gonna try again to talk about your career as an early career researcher and your PhD and what it is you did for your PhD, specifically your work with cancer, exercise and cancer, and then we're going to talk about your article that was titled "Exercise Improves VO2max and Body Composition in Androgen Deprivation Therapy-Treated Prostate Cancer Patients." So before we get started, you've been working at Murdoch University for quite some time. You started here just about a year after me. But more importantly, you started your position here while you were still doing your PhD. So you took on a full-time academic role while you were in the midst of data collection and analysis and write-up. There might be a few PhD students who listen to this podcast who could be in a similar position and might be looking for jobs now and not done with their PhDs. Would you be able to discuss that situation for yourself and how you handled?
Yeah, sure. Yeah, my advice is don't do it. But I understand it gets to be quite a stressful time towards the end of your PhD because you do start thinking, right, now I need to find a job. And if the timing's not always perfect, it's not always going to perfectly align with you submitting, getting your grades back, and just walking into a job. It doesn't happen like that. So when this opportunity presented itself, I thought, because I did want to stay in Western Australia, I thought it was a great opportunity and to come into a really young emerging program. So I did take the job. I still had the tail end of my data collection to go, and I probably realistically thought I was about 6 months away from finishing. And that took me another 2.5 years to do that 6 months of write-up. It's definitely challenging, and I think my old PhD supervisor, Rob Newton, explained it to me. He said for the first year that you're in academia, you're just trying to keep your head above water, and that's exactly, I think, what happens. It's really challenging. So I think when I first started, I had to, within a month of being here, I had to write an entirely new unit and develop that unit. So write all the assessments, lectures, labs. So as a new academic, I really was thrown in the deep end. It was good, I think, because I've looked back now, I just had so many opportunities afforded to me because of what I did really in the early days. It really was a challenge, but switching from a full-time researcher mode where you had all day, every day to write, collect data, whatever it was, to just having snippets of time throughout the week that you could really work on your PhD. And that was quite challenging.
And so would you say that do you think the hardest part was learning, taking on the academic portion, so learning about teaching, learning about curriculum development, or do you think it was equally was it just as hard to kind of try to find the time to, again, you're still collecting data, you're still trying to do writing up. So which one did you find to be more difficult, if one or the other was?
Yeah, I found switching on and off from teaching mode to research mode difficult because, as I said, you had all day. If you needed to write a chapter or something, you had all day. You could get there in the morning and just write. Whereas what happens when you walk into academia, you may have a lecture in the morning, you may have a 2-hour break, and then you have a lab or you have a meeting to go to or another committee meeting. So you have a real small snippet of time where you can be productive with your research. And I really struggled from switching from that teaching mode back into the writing mode. So that was a challenge. And also I found in academia, the first time, I think it's like anything, not just academia, but the first time you do something, it just takes longer. So the first time you mark your mid-semester exams takes a lot longer. The first time you write an exam, you write a lecture, it just takes longer. You become more efficient, the longer you are an academic, as you know. But at first, everything just takes you a long time. So you may just have a standard teaching workload, the same as everyone else, but it's just taking longer the first time you do everything.
So that means that this podcast will take half the time, I guess, because it's the second time through. But so how did you? It's a pretty high level of stress to be both learning new academic position and then also collecting data. And again, your data wasn't easy to collect. It was quite a large, decent sized study. So how did you handle that? I mean, I know you said you hoped it was 6 months you're going to be done in, and then all of a sudden it became 2.5 years. And so there was some delay in the process. But how did you cope with the two kind of things pulling on you at the same time?
Yeah, it was tough. And I would lie if I said that there wasn't times where I genuinely thought I wasn't going to finish my PhD. I think there was times where I really did question it, but I think that's normal for anyone who does a PhD. I don't think it's a real PhD unless you at some point think you're not going to finish it. But yeah, trying to find the balance and find the time to do both, probably what you would term full-time jobs. You come in with the best of intentions, and I've met other early career researchers that have said exactly the same thing. It's great. They're going to allow me time to finish my PhD off. I just need to write this last chapter or whatever it is. And it doesn't always happen like that because you have a full-time job that is your responsibility and what's making you the money. But at the same time, you know to keep that job, you need to finish your PhD.
And so did you have, I'm assuming you had a fairly decent support network around you then. And if that's the case, how comfortable were you? Did you discuss this a lot? Did you discuss the stresses that you were under a bit, or did you just kind of internalize it, or how did you handle that?
I'd say I probably internalized it. Yeah, I think probably didn't talk. You don't want to admit that if you're struggling or if it's taking too long or I think for me, I was coping fine with the academic side of things. I was enjoying the teaching. I was still doing the research. But yeah, in the back of your mind, you are thinking, can I still do this? Can I finish this PhD? And that was always constantly, every day was in the back of your mind that you're not finished your PhD yet. You're walking around with everyone who's Dr. such and such and you're still a mister. It's constantly in front of you that you haven't finished. And yeah, it was stressful. But it was also all the more rewarding when I finished.
I don't know if there's actually was a time period where this happened, but you know, you talk about you may have thought that you couldn't finish it, and it may not be something you're going to be able to get done, and you're internalizing that. Was there a point where you just realized you could? Like, was there a day or a time or a point where you thought, okay, actually, it's going to happen. I am going to get it done, and I don't mean the day you finish it and the day you sign the papers, but was there a day where you really realized that all the stuff that was happening had all kind of shifted in your favor and you were going to complete it?
Yeah, I don't think there's ever a one day. I don't think it's you wake up and go, okay, I am going to be able to finish this. It happens over probably weeks, if not months. And anyone who knows when they're orbit dissertation, that things you want them to speed up, but they slow down because your work's you're waiting for feedback to come back. You have to appreciate that takes time as well. So there is a bit of time sitting on your hands waiting for feedback to come back, which probably frustrates you a little bit more as well. But now being on the other side of that as a supervisor, I understand that it just, you're being pulled in so many directions as an academic that you may not have the time to get back to that work. So yeah, it can be a frustrating time. That last 3-4 months of your PhD can be quite a frustrating time because you work flat out for however much time to put it back into review to one of your supervisors, and then you sit and wait. A lot of the times there was something else you could do, but towards the end there was less and less that you could be doing. So it just probably over time. I think it's over time you started to realise, oh, this is now achievable, and this is possible.
Okay, so let's transition then to your actual PhD, and we'll talk a bit about that. Today we're going to focus on a paper that looks at the effect of exercise on individuals that were suffering from or were treated for prostate cancer. And so you were working in the area of exercise and cancer, and you're working with some fairly large names in Australia in terms of exercise and cancer, or internationally renowned names. But I know that you had two opportunities going into a PhD. I know that you had an opportunity to possibly take a job in sport, so do a PhD in sport, and I know then you, of course, took the opportunity to work in cancer. What was it that drew you to that area as opposed to the sport performance side of things?
Yeah, I sort of did hit a fork in the road at the end of my master's. So I did my master's in exercise physiology, so working with cyclists. So I looked at hydration and thermoregulation. Towards the end of that, and you're right, we did have some world-renowned researchers. So Professor Rob Newton and Professor Daniel Galvao, and later on Professor Dennis Taff were my three supervisors. So had some real world leaders in the cancer field, and it really started to interest me that there was a little bit more to it than just the sports side of things. I still wasn't sure, so I ended up applying for 2 scholarships. I applied for a scholarship that was a joint venture between a university and a professional sporting team, and the scholarship that I ended up taking with ECU, so the Exercise Medicine Research Institute. I was fortunate enough to get both, so that didn't help. So I ended up having to make the decision. And it was really tough. And I don't think it took me a while to adjust to these, to taking on the position. I thought career prospect-wise, funding-wise, job security-wise, I thought the exercise rehabilitation side would probably be maybe a little bit more sustainable for me and a little bit more job security than elite sport. Not to say I didn't enjoy. I loved working with athletes. But then, jumping into the sort of chronic disease was a massive shift. I went from working with guys who you did not need to provide them with any motivation. They were cyclists performing time trials. You just said ride as hard as you can, please. They were elite level athletes who were just used to pushing themselves. Within a year of finishing that research, I was moving to chronic disease with an average age of in their 70s, and I was teaching men how to walk on a treadmill. So it really shifted from that elite level sport to teaching men how to walk on a treadmill and to have walked into a gym for the first time in their life.
So you had 2 opportunities, and you chose the opportunity that maybe had the most job security or potential in the future. And I wonder sometimes as PhD students, and especially you go through a master's program and honors program, you do something that you find interesting, that you like because your supervisor at the university is doing that. And it's I think an important thing to talk about is that sometimes maybe you go do something else that, even though isn't your biggest interest, is going to be the best for you in your future. And so, so it sounds like that's how you weighed up those 2 choices.
Yeah, that's exactly how I did go into my master's. I loved sport, in particular was triathlon, and my supervisor was a triathlete, and I think that's probably how I fell into exercise physiology. I loved triathlon, and he was a triathlete, and I did cycling based research and really enjoyed it. But it got to a point I did have to think, I love triathlon and everything about it, but how many jobs were there going to be for high performance managers in triathlon in Australia or even in the world? There's not many. There's not many jobs. So when you look at job security and options, it's limited. Not to say that they don't exist, of course. There's people in those jobs now, but in terms of job security, I looked at the rehab or an aging population, looking at different things of where I saw exercise physiology or exercise rehab heading. I thought there was a real market there, and it was really taking off. I think that accredited exercise physiologist title that with ESSA, it was really only in its infancy. So I think it's been vindicated. I think it really is starting to take off now, and really starting to see the recognition with Medicare and other private health with becoming an accredited exercise physiologist.
Okay, and so you chose to go into the area of exercise and cancer, and primarily you focused on men who had been treated for prostate cancer. And so maybe you could just walk us through the types of treatment that someone might come across if they have prostate cancer, and then maybe the side effects that are the common side effects to those treatments and then we'll kind of link that later on to your paper where you looked at some of the exercise effects.
Yeah, so really, in a nutshell, my PhD was looking at men with prostate cancer, obviously, who were undergoing androgen deprivation therapy. So the real early landmark work in the 50s and 60s that was done on prostate cancer identified that, before I get to that, I'll jump back. We do know that cancer is just an uncontrolled growth. It's some sort of just uncontrolled proliferation of cells. And so the really early landmark work that was done in prostate cancer identified that obviously something needs to be feeding that cell growth. And in the case of prostate cancer, it's testosterone. So we understand that the testosterone is what's causing the cancer to grow. So what followed on from then was understanding that if we can suppress testosterone, we can control tumour growth. And it's been a really successful drug. So the androgen deprivation therapy has been very, very successful. Now, it's very successful in controlling tumour growth, but we think that we produce testosterone as men for a reason, very, very good reasons. So we know that now the side effects of androgen deprivation therapy in terms of cancer control is very good. But because it's very good, men are living for longer on this drug. Now, when we produce testosterone, or when we don't produce any more testosterone, or don't uptake the testosterone, depending on what drug you're on, we see increases in fat mass. We see a reduction in muscle mass, increased abdominal fat, so increased risk of diabetes and cardiovascular disease. So there was some early work that showed that men once undergoing or initiating androgen deprivation therapy, they were more likely to die of cardiovascular disease than they were of prostate cancer. And so that really highlighted a need that we needed to do something, that we really needed to identify how can we reverse these side effects or mitigate the negative outcomes resulting from this androgen deprivation therapy. And that's really where my PhD started.
So then the exercise, well, at least within your PhD, you were targeting more of the cardiovascular risk factors that would be associated with other issues that might down the track result in death. But exercise is used within a lot of, well, at least within literature, is being used within various different cancers, specifically, breast cancer. There's lots of research with exercise in breast cancer. So are the benefits similar? Would the benefits be similar between the two different types of cancers for the use of exercise, or are there similar benefits, but then also very specific benefits that affect each group differently?
Well, really, yeah. Broadly speaking, that exercise in cancer, or exercise oncology, is what the field is now being termed. We're seeing benefits across the board: breast, colorectal cancers, whatever types of cancer groups. We're seeing really, really good outcomes from implementing structured exercise programs. Now, the exercise, when we really get down to that nitty gritty, is that we do start to see targeted exercise interventions. I think we're going to talk about that a little bit later, and what I did and how we targeted specific side effects and how we manipulated exercise programs to target those side effects. But really, yeah, exercise pre-cancer, post-cancer is really shown right across this cancer continuum. Exercise has a place, and that's really where I think the field's getting to now, is it's showing that exercise has been proven. Now, we're seeing these long-term randomized controlled trials coming out that we're starting to see benefits of treatment coping, and we're seeing increased survivorship because of with exercise, and reducing risks of cancer recurrence. But then we're also looking on the prevention side of things. So there's some really nice literature now that's showing the preventative effects of exercise, particularly in breast and colorectal and prostate. Particularly, they're following the funding sources. We know breast cancer is the most common cancer in females, as prostate cancer is in males. So that's where a lot of the research is sitting. That's also, I should know, outside of skin cancer. But really, the male equivalent of breast cancer is prostate cancer, and that's where a lot of the research funding has been sitting, and that's sort of where a lot of the research has been going on.
And in a bit, we're going to talk about your paper, and that was really looking at exercise post-treatment. But you made an interesting point about the pre-treatment use of exercise, and I know that area has been growing in research in terms of, and you talked about survivability and handling treatment, but can you maybe speak about that a bit more in terms of what you mean by that? So how does engaging in exercise, you find out that you have cancer, and before treatment, how does the exercise or engaging exercise affect your actual treatment outcomes?
Well, yeah, I think where exercise and cancer is now is where we were, we're getting past it, but it's where we were with exercise and cardiovascular disease maybe 20, 30 years ago. When someone had a heart attack, classically we would have prescribed bed rest. We didn't want to stress the heart or the cardiovascular system, so we prescribed rest. Now we know that prescribing sedentary behaviour is actually the worst thing that we can do, and these people are becoming a lot more mobile very soon after that myocardial infarction. So exercise and cancer is looking at a very similar thing, although it's been delayed in its rollout, I think. So the message is starting to get out there that when someone obviously is diagnosed with that cancer, it doesn't mean we should stop exercising. We do see that happening. We do see people start, just that classic thought is still, I need to conserve energy, the body needs to heal, it needs all of its available energy to target this cancer, which we know isn't the case and is actually to the detriment of your cancer diagnosis if you aren't physically active or undertaking exercise programs. So some of the research now is showing, if we just look at things like being able to tolerate chemotherapy or radiation therapy, so it's showing that when exercise is implemented during these courses of chemotherapy, the ability to see through that treatment, if it's a 6-week course of chemotherapy, the ability to get to that 6 weeks obviously is the optimal outcome. when the oncologist prescribe that chemotherapy or that radiation therapy, they're obviously prescribing the optimal course. Now, if you can't make it through that, then it's obviously not the best treatment option, or we're not getting the best out of that treatment option. Exercise is now being demonstrated to show that treatment coping and preparedness for treatment as well is enhanced.
Okay. And staying along that same line, because we haven't yet transitioned to your paper, let's say that you are diagnosed with a cancer, and your thought is, okay, yeah, I want to do everything that's the best possible scenario for me. So I'm going to start exercising a bit more, make sure I'm fitter, make sure I'm healthier, so when I do go on these treatments, that I'm going to be able to sustain that. What kind of exercise are we talking about? And is there a general guidelines at the moment to tell you what you should do, or should this be? And we talk a lot about within exercise science about being very specific. So you prescribe individualized programs. Is there a kind of a generic guideline, and then of course becomes more specific the fitter you get, or what should they be doing if that's the case?
Yeah, I think as exercise professionals, we haven't done the best job at promoting exercise because we've made it so complex. Depending on what you have, where you have it, this is what you should be doing. There's been a raft of different guidelines. So in its simplest sense, I would say if there has been a cancer diagnosis, just get moving. I mean, we know that dose-response relationship. Doing something is better than nothing. Obviously, doing more is better than some, but definitely some is better than none. And so we know that just doing something. But if we want to look at just general guidelines, if we just find a one-size-fits-most approach, so most of the clinical guidelines now are saying that 150 minutes of aerobic, moderate intensity aerobic exercise, or 75 minutes of vigorous, and then 2 to 3 days of resistance training per week. Now, you'll start to see, if you look at consensus statements for cardiovascular disease, you look at consensus statements for cancer, pulmonary disease, you look at the different consensus statements, they're all coming out with very similar general guidelines. Where it gets a bit more specific, like we said in the case of prostate cancer, we've started to identify a number of side effects, or loss of lean muscle mass. Okay, so now we should be targeting more of that resistance training. We're seeing an increase in cardiovascular disease risk factors. Okay, what type of exercise can we do that would mitigate those risks? So in its generalist sense, we can follow that real general 150 minutes of aerobic exercise a week, supplementing with additional resistance training 2 to 3 times per week. And then following on, I would recommend getting in touch with an exercise physiologist or appropriately trained exercise professional who has experience in cancer care.
So it's interesting because it seems like, and this is the same thing in cardiovascular disease, exact same issue, is that we overcomplicate things with frequency and type and duration and this and that, and we've kind of gone back to some guidelines that are very generic. And but the guidelines for the cancer seem to be the exact same guidelines for cardiovascular disease, but they also seem to be the same guidelines for something like just healthy aging or being healthy in general. And so really I guess my take home from that is that someone who has cancer should be treated no different than if they hadn't had it in the first place. They should be trying to do the same type of exercise that they would have been doing before the diagnosis, or they should have been doing before the diagnosis. Now that they have the diagnosis, that treatment might be a bit more important in terms of them getting treatment, but it's still the same type of prescription.
Yeah, and we've discussed this before, and we look at the consensus statements are what we term quite generic, and they're very, very similar now, depending on what you have. But really, it comes from the literature, the safety and the feasibility of the training. So is it okay? So some of the early stuff that was looked at, and my supervisor, Daniel Galvao and Rob Newton looked at, and Dennis Tafe, is it safe? Do we see, if we're trying to suppress testosterone, does promoting resistance training result in spikes in testosterone? Because typically in a healthy population, we would see an increase in testosterone in men who would undertake resistance training. So really, we had to take it back a step to say, not only should you exercise, here is the demonstrated evidence that says it is safe. So no, we don't see spikes in testosterone. It would be counterintuitive to put someone on a suppression drug of testosterone and then spike their testosterone through exercise. That doesn't happen, but we needed the research to show that it's safe. So yes, the guidelines are very similar, but really I think where we came from was the safety and the feasibility to make sure that exercise was safe. Or more so, how do we make exercise safe for this group? Really going away from yes you should or no you shouldn't exercise, because whenever we say no you shouldn't exercise to someone, we're prescribing sedentary behaviour. We're telling them to be sedentary or not do anything. We know that's the worst thing that we can do. So now we need to look at, as exercise professionals, okay, given your condition, given your risk factors or your side effects, how can we make exercise safe for you?
Okay. Well, I think that's a great place to transition into your actual study. So this paper was published in 2017, and it was published in, I think, Medicine, Science, and Sports and Exercise. Is that correct?
Yeah, that's correct.
Yes. And the title of the paper was Exercise Improves VO2 Max and Body Composition in Androgen Deprivation Therapy Treated Prostate Cancer Patients. What I'd like you to do over the next few minutes is just maybe outline the rationale for this study, so what it was you were trying to achieve, why you were trying to do that in the first place, then what it is that you actually did in terms of running the study itself, what were the outcomes that were the most important outcomes that you received or that are in this paper, and then what you think that, what does that mean? So if you saw changes, what was your kind of conclusion about those changes?
Okay, I'll go back to the beginning. Where this originated from was that my old supervisors, so my PhD supervisors, had done some works, but Daniel Galvao had done this through his PhD, was really looking at the beneficial impacts of aerobic and resistance training in this population and saw some really promising results from a 12-week intervention. So we saw promising improvements in strength and endurance and functional ability. We just didn't see any changes in fat mass. So we saw body composition changes, obviously because we saw lean muscle mass changes, but we didn't see fat mass changes. And that's where I came into it, is we started to see these increased risk of cardiovascular disease. And we know that fat mass, particularly trunk fat, is one of the key findings, so blood pressure as well, but fat mass is one of the leading indicators or risk factors for cardiovascular disease. So we really wanted to take that preliminary research from that 12-week short-term sort of intervention and refine it and make it bigger. This was part of an NHMRC study that my supervisors successfully obtained funding for. I was basically the PhD student attached to that grant. So we ran a 6-month trial, so a long-term trial. And what we did, where we made it different from what had been done in the past, is often what had happened, the really, really early work had looked at just home-based, really low-level aerobic training programs. And we would often refer to them as just home-based walking programs that saw some benefits. Then we started to see a bit more resistance training focused programs, but very few, and no one had done it in a long-term study at that stage, had put the two together. So well-supervised, structured aerobic and resistance training programs. So in that 12-week study that I just spoke about, we saw those real beneficial changes in muscle mass, but we didn't see reductions in fat mass. But when we looked at the overall volume of aerobic training they did, was actually quite low in terms of what we would normally prescribe with that 150 minutes a week, which we just spoke about. So what we did with this when designing this study was we made sure the men hit 150 minutes a week of aerobic training and then had them in the gym twice a week undertaking structured progressive resistance training. And it was very successful. We found that, and that's what we proposed, that the lack of differences in fat mass changes and overall cardiorespiratory fitness was there just wasn't enough volume there. So we increased the volume. And we reported that we saw significant improvements in VO2max, and we saw significant reductions in fat mass or a significant interaction in fat mass, along with the things we already thought we would see. We knew we were going to see improvements in lean muscle mass, strength and endurance because we'd seen that previously, albeit in a shorter time frame. But this really started to roll it out. We had 5 centres across the west or the Perth sort of metro and just outside outer metro area. So this was really about rolling it out and really looking at the large scale or the upscale ability of this.
Okay, so fat mass is one of your major outcome variables, and of course it's quite important in terms of risk for cardiovascular disease, risk of diabetes, and then you were saying beforehand that many people who get treated for prostate cancer, they might end up dying actually from cardiovascular disease because of the side effects for the treatment. So you went to do you think it was the longer intervention itself, the more aerobic exercise itself? Did you control for diet or things like that? Or what do you think it was that was the greatest stimulus to see those changes?
Yeah, I think it really was keeping the resistance training very similar to what the previous protocols have used because we knew they worked. We knew that resistance training worked, so we didn't want to change that. But we did know that there probably just wasn't enough aerobic training in there. So how we did that, we implemented a more of a home-based program as well as the aerobic intervention that we would do in the gym settings twice a week. So outside of that, they were prescribed, had home-based activity logs, they had a heart rate monitor, which they would log for their overall. So I think there was a number of factors, but I think the increased dose of aerobic exercise significantly helped, especially when we're looking at cardiovascular risk factors, so that fat mass, blood pressure changes. we saw that a lot in aerobic training, but obviously well supplemented by resistance training. It's what we would recommend generally. We would recommend, and those consensus statements do show that aerobic and resistance, but it shows that there's an adequate amount of aerobic and resistance training resulting in these favourable outcomes. Now, the big change was looking at, can we really upscale this from a 12-week to a 6-month intervention? That posed its own series of challenges. These men the youngest was 49 and the oldest thing we had was about 90. So we had a real spread, but typically they're around that 70 years of age. So a 6-month intervention was difficult, was a lot more difficult than 12-week intervention, because in 6 months, these 70-year-olds, they were retired. They wanted to go away in their caravans up north in the cold. So it's very hard to run a 6-month intervention avoiding winter or that grey nomad pilgrimage. So that's something that was interesting, but also showed that we could see these favourable impacts in a longer-term intervention.
Well, that's an interesting point. Two things. One is you talk about the length of intervention and that it presents its own difficulties, because once you extend the length of an intervention and you're asking people to come in and do exercise on multiple days per week, more often than not, people have other things to do in their life beyond do your study for you. And you saw a dropout rate of about 21%. How does that stack up against other? So is that rate high, or did you find that the prostate cancer participants had kind of a similar dropout rate, so that it has nothing to really do with the disease itself, but more just lifestyle?
Yeah, we saw the attrition rate was higher than the 12-week program, and we think it's because of that. We know that a lot of people can stick out a 12-week intervention. It's a 3-month intervention. To go to 6, it's a long term. You said that a lot of things can go on in their life in that time. So that 20% wasn't completely unexpected. I think in our power analysis, that's what we did work off at that attrition rate. It is difficult to keep them, but what we ended up finding, once they would make it through those first couple of weeks, so once they got to the point where they could start to feel different, they would start to actually see the differences, feel the differences, and start feeling better. That's when we really had good retention rates, because these men they started seeing it for themselves. We told them it was going to work. Their oncologist told them it was going to work, but until you start to see the rewards of your hard work, that's when I think you really get that buy-in to start with. But the men that finished that program were really saw significant findings. And
when do you think that time period occurs? And so what I'm getting at here is, for everybody who listens to this and is thinking about exercise or doing exercise, there is that period of time where nothing is happening and exercise is not comfortable. It's not, for a lot of people, it's not an enjoyable endeavor to go out and expend that kind of energy or lift weights. How long, what do you think you need to wait before I know it's all individual, but I mean, what would your advice be to someone who's either starting a program who's healthy, aging, or someone who maybe prostate cancer, who's been treated and starting to exercise? How long before you think you start to see some changes?
Yeah, that's a good question, because we looked at just 0 and 6 because we wanted to look at a 6-month intervention. We've seen changes a lot smaller than that, and depending on what we're looking at, we saw the 6-month, I think, was because for that aerobic training, we really wanted a 6 months. But I think the key we found, particularly with this group, was starting very light. And I'm not talking about for the first month, 2-3 months, was that first session or that first week or two was not overloading, because the other issue we had was these men just wanted to come in, bull at the gate, just really start lifting this heavy weight. And what does scare people off most is DOMs. So, if you think about, you've got these 70, 80-year-old men that have never stepped foot in a gym. All of a sudden, they're feeling pain that they haven't felt for a very long time. A lot of them were detrained. So the delayed onset muscle soreness was real. So trying to ease them into that program for the first week or two, start relying on that repeated bout effect, and then really start to progress their program. So after probably that month, 6 weeks, we do start to see that they're improving. They can, and particularly in resistance training, that's where we saw it the most, because they can physically see it. They can see they're adding on an extra kilo or 2 or 3. They're adding on an extra plate in the gym, and that's motivating for them.
And so you saw decreases in fat mass, you saw increases in VO2max. Did you take any measurements, functional outcomes? So when we think about, talking about quality of life, people don't measure their quality of life in their VO2max. They don't measure, they might measure a bit of their quality of life in what their body shape looks like. But did you measure, when we think about quality of life, we think about mobility issues, we think about being able to be more independent. Did you take any measures like that?
Yes, we did. It's not included in this. Because this study was so large, we actually had an extra arm to this study. So we had the intervention group that participated in the exercise. We had a control group, but there was actually a third group, which wasn't reported in this study because it was just such a large intervention. But that study was a bone loading protocol. So we identified that a loss of bone mineral density is very common in this group. But bone density changes ties back to that question from before, was when do we see changes? We don't see changes in bone after 6, 12 weeks, 6, 8, 10, 12 weeks. We see these changes more in chronic adaptations. We see changes in bone resorption markers, so we can see blood changes. But until we see, it's a lot longer to see these changes. So
we're talking about the functional outcomes.
Sorry, I got caught in a tangent.
I could see your face looked a bit confused at that point. Yeah, that's all right.
We're talking about functional outcomes. So yes, we did measure them. No, we didn't report them in this study. But I do know what they were because, we did analyse them at the time. So quality of life measures we looked at. So we looked at some cancer-specific questionnaires there as well. So just the generic quality of life, but then we looked at the cancer-specific quality of life. We also looked at functional outcomes as well, because I don't think it really matters what you can bench press in the gym, what you can leg press. So we use stair climb, forwards, backwards walks. We use some different types of sit-to-stand tests. So we wanted to see, are these strength changes translating to functional outcomes? And yes, absolutely they were. So we started to see some very good changes in quality of life, but also in fatigue was the other one, because fatigue, I'd say, fatigue's one of those really nondescript side effects. It doesn't matter what cancer, breast cancer, colorectal cancer, whatever cancer you're looking at, fatigue is one of the number one most widely reported side effects in any cancer treatment. So we saw favourable benefits, favourable adaptations in levels of reported fatigue as well, which lends itself to seeing an increase in quality of life.
So I'm going to ask you a difficult question then. So what do you think it is that then fatigue is insanely multifaceted? So, I mean, it could be a number of things, but do you have a feeling about what it was about your intervention that would have had an impact on someone's levels of day-to-day fatigue?
Yeah, really good question. And I think you sort of answered it there, saying that it's incredibly multifactorial. There's a physical component. So we know by making these guys stronger and fitter, they were able to participate in these activities of daily living with a lot less stress or metabolic demand, because they were stronger, because they were fitter. Things like walking around the shops, getting out of bed, lifting, pushing, those types of everyday actions became easier. But then there's the psychological aspect as well. So of course, while we did monitor quality of life, there was also another really interesting impact of this study. And what I found with this group was that they're guys that are probably my dad's age and probably a bit older, so grandparents' age. That generation of males didn't talk about their feelings. They didn't attend support groups, and they didn't really sit down and talk to each other about how they were feeling. And what we found was these men were forming these informal support networks. You sit a bunch of guys at this age down and talk about their feelings, no one's going to talk. But for some reason, we put them in a gym, and these guys talked about their side effects, they're very detailed side effects. They were all going through the same thing. And I think the gym broke down barriers. It gave them this informal setting where they could talk to each other. And that was definitely a side of things that we didn't really set out to achieve, but I think that was also a big... of course, we targeted the physical side of things, but the mental and the coping, to see that there was other guys going through exactly what they were going through, I think that was also quite important. And that sort of does tie back to fatigue, because we're looking at quality of life as well.
From the outcomes from the study, there seems to be nothing negative coming out of the study. I mean, that's not a criticism at all. What I'm saying is that it appears that doing exercise with people who have been treated for prostate cancer, with that type of therapy, there's only really beneficial effects that come with the exercise itself. However, when you were recruiting your participants, you recruited something like, and I'm reading off a screen here, I don't know this off the top of my head, but it's 256 people were recruited, but you only had 111 who were willing to participate. Now, I say only 111, that's still a big number for a study, but that means there was a large portion of people who just didn't see interest in doing being part of the research, or chose not to participate. And when we talk about all the benefits that come from it, what does that tell you about? I mean, so how do we get 256 people to agree to participate? You know what I mean? So what do you think the barrier, I mean, how do you think you now promote this to a much wider audience?
Yeah, this is something that I'm really interested in since doing this PhD. We know that exercise works. We knew before this study that the shorter term worked. We now know the long term works, but we're still only getting 50% of people to say yes to it. We had some really good oncologists, particularly radiation oncologists, referring in this study, and they did a really, really, really good job of selling the exercise. Maybe sometimes a little bit too good when someone found out they were in the delayed treatment group. But yeah, it's frustrating, to be honest, to say why aren't more people doing it. But we need to look at barriers to participation. Everyone had what they perceived as a valid reason for not participating in that exercise. I think as time's going on, we're starting to get a lot more referrals now, and people are being more proactive at asking their oncologists and their GPs, what about exercise? What should I be doing? And that's the feedback we're getting from specialists as well. They don't have the time to discuss exercise programs. That's why referrals are really important for us. But they just don't have the time to prescribe exercise. But I think it's becoming a lot more accepted now. Anecdotally, I've got no evidence to support this, but I just seem to find the referring doctors and the doctors that were really on board, and throughout my career, so I'm an accredited exercise physiologist as well, what I've found is that the doctors that refer are typically fit people themselves. A few of the oncologists that referred to us were cyclists. They've been running groups together. So I don't know. Maybe I've joked about maybe that's where we should be targeting. Maybe we don't need to be putting out flyers. Maybe we need to be training the oncologists or the urologists or the specialists. And if we get them fit, they can be the sales or the promoter for that exercise intervention. So I don't know. We need to look at doing something differently, because at the moment, like you said, we know it works and we're getting less than 50% doing it. Going away from chronic diseases just for a second, is that general population, we're doing less and less exercise. We're knowing more about exercise. We know more about the beneficial impacts of exercise than we ever have, but there's less and less people doing it. So something's breaking down.
Yeah, and it sounds, in this instance, it sounds like the doctors or their oncologists or radiation oncologists had a big impact on whether they participated in your studies. And so, I think more and more we're seeing exercise making its way into physicians' mindsets in terms of especially GPs. Maybe, I guess, the way to go is to try to help ensure that type of information is making its way into medical schools. I don't know. I have no idea. It was interesting that because there's so many great benefits that came from your study, it was just interesting to see that only 50% of the people who I would assume that these benefits were already known within the oncology community where they would be prescribing, but it appears that may not fully be the case.
Yeah, possibly. And it was free. It was a 6 month. These guys got gym memberships, heart rate monitors, access to unlimited sort of exercise programming. So we did remove certain barriers, but it is really interesting. I think it's something where research is looking now is at how can we do it, and embedding exercise physiology services and exercise within the standard care of cancer is where we're progressing to. We're not quite there yet, but there's some people in the field that are really pushing that. All right, you see your GP, then you go off to your specialist, you go off to your radiation oncologist, urologist, whoever you go see. The next person should be, okay, here is your exercise professional, your exercise physiologist, to talk about how you're going to reduce your side effects. It almost should be in one door to see someone, in another, and in another. If they're located, it seems to, I think my theory is if they're all located in the same centre, so if they are hospital-based or some sort of clinic-based, we may see better pickup rates.
We're getting kind of towards the end of time, but I want to ask one final question. So going all the way back to the beginning, right? We talked about your PhD took longer than you thought it was going to take because you had a job, and you work with a population that was quite different than what you had done as your master's. And it's apparent that there was lots of work to do and a lot of stress involved within the whole process of getting this all done. What was the best part?
I think that sell from moving from the sport to the chronic diseases, more challenging, but more rewarding, far more rewarding. From a personal perspective, other people will disagree with that, but I found it far more personally rewarding. I had a participant, without going into too many details of this person, but he was a school teacher. And he, due to the surgery, which is a very common side effect, was incontinence. So he had to wear an adult diaper, which for him as a school teacher was humiliating. That's how he explained it. It was humiliating. He was very self-conscious because obviously he was at a school with quite immature, to be honest, kids, that he was really worried about that. And we found throughout the course of the program, because he started to regain muscular control, there was more retraining. Although we particularly didn't target the core, the types of exercise, the whole body or multi-joint exercise we were doing, obviously were targeting the core. And he got to the point where he didn't have to wear that device anymore. And to him, that completely changed his life, because that changed his day-to-day living. And that for me was really powerful. So from 12 months prior, I was trying to eke out a couple of seconds in a time trial for a cyclist, and that was great, and that was rewarding. But now I'm shifting towards seeing guys. It's making a significant difference to their everyday life. It made a difference to his life, his wife. It helped with. He became more relaxed and at ease. She became more relaxed and at ease. So just seeing the differences that you can make in this field, I think more than makes up for that. Yes, sport's cool, and I love the sport and the elite sport, but this more than makes up for it.
Well, that is great. Just as good the second time as it was the first time.
I hope so.
So if someone's listening to this and they're interested in what it is you're doing, or what you did in the past, or what you might be doing in the future as a researcher, how would someone get in contact with you if they wanted to chat with you?
The easiest way is go to the Murdoch website and search for my name, Brad Wall. So otherwise, directly is just my email. So b.wall@murdoch.edu.au. But if you search for me on the Murdoch website, that's the easiest way.
Easy. Well, thanks again for coming back in for the second time to do this interview. Like I said the first time, that no one will ever get to hear again, is that you did some really important work in the field, and the work you've done has kind of helped lead on to further research and work in this area, especially with the use of exercise. And based on your outcomes, I mean, it's apparent that it has such a profound and important impact. And I just thank you for coming in and sharing for a second time.
Oh, thank you. I might even see you next week for a third time.
That concludes another episode of Science from the Source. I hope you enjoyed this episode, and if you did, please take a minute to rate the show. And please help the show reach a wider audience by telling your family and friends. If you have any questions or comments about the content of the show, or an idea for future episodes, please email me at sciencefromthesource, that's all one word, @gmail.com.